I'm glad you are because I am too. He's actually my optometrist. Um,
Oh,
couple of things I didn't know before he was actually my patient, or I became his patient, was that he is a military veteran. So for all you veterans over here, this is the first official veteran that we've had present for us. And I'm going to read this because this is unusual for us. Um, he started his professional career in the United States Army as captain and clinical optometrist. He worked in Fort Jackson in Colombia. He finished his military career at Madigan Army Medical Center in Tacoma, Washington, where he was promoted to the rank of major. But most importantly for us, he did receive two Army Commendation Medals in 2019 and 2021 for his clinical care and service in the Army. So we're very, very fortunate to have him. He's, of course, been a graduate of School of Optometry at Southern College, but also Dartmouth College's Tuck School of Business. I got try to get it all out. We don't normally do all of that, but I just really, quite frankly, want to draw attention to the fact that you're one of our military veterans, and we really do appreciate the work that you have done serving our country and taking care of all of us. So today, Dr. Gaasch is going to tell us a little bit more about how we need to take care of our vision. And as we get older, vision preservation is a big deal. And I'm because you're a veteran, I want to stress this. A lot of people in the military or who have been in the military do have vision problems later in life, and they're not taking advantage of their military benefits for overall health care and eye care in particular. Lots of people have had some horror stories about advanced glaucoma surgeries that have gone wrong. If you can help us do what we need to do to take better care of our eyes. I'm no longer wearing mascara in my waterline, ladies. You can't do that as you get a little older.
Awesome. Yeah. And thank you, Dr. Parker. And I'm glad to hear that. And that's something we are certainly going to talk about in today's lecture. So let me share my screen here. I can figure that out. Here we go. Okay. All right. So again, thank you, Dr. Parker. I was talking to Dr. Parker about dry eye disease, and she felt like the explanation that I gave her on it would be great for this platform. So that is what I'm going to give today's presentation on. So yeah, my name is Dr. Gaasch, and I did spend about 8 years in the military where I did comprehensive eye exams for our service members, beneficiaries, and retirees. And through that experience, I actually worked a lot with acute clinics and providing consultative care, and did a little bit of that on deployments as well. So got to experience some very dry environments while in the Middle East. Here at Emory, I do comprehensive care. I work with our low vision patients as well as one of our specialists. And through that, able to help manage patients with permanent visual impairments and some with legal blindness. And then I also do consultative care for the emergency departments and the ICU as well. So and I'm going to be discussing some, brand name things, medications, diagnostic testings, but I have no financial disclosures. Okay, here we go. All right, so kind of the goal for the presentation is we'll go over the traditional dry eye lecture where we'll talk about what dry eye is, the diagnostic and treatment options that we have available, and then some overall considerations for just discussing prognosis with patients and also follow-up care. But as an optometrist, one of the main things that I like to focus on is the vision aspect of it. I think that we'll spend a lot of time on patient education and identifying a lot of the risk factors that are involved. So my learning objectives are here. Want to define dry eye just in general, giving all of us a really good understanding of what it is and what causes it, and then understanding when to seek treatment, who to seek treatment from, and recognizing a lot of those risk factors, ones that we can modify as the patient, but also as a healthcare professional, how we can help some of our patients know what those risk factors are and work on getting rid of some of those or managing those with their primary care providers. The last thing is just talking more so about an interdisciplinary approach to treatment of dry eye disease. It's something that I have a special interest in is because of wanting to improve patient outcomes and the healthcare system in general. It's one of the reasons I went on and did my master's in healthcare delivery science, was trying to find better ways to create or to really promote that patient-centered care in order to improve patient outcomes. So, what is dry eyes? We hear it all the time. Well, the kind of common names that we see diagnostically or even just talking about it are dry eye disease or dry eye syndrome, ocular surface disease, dysfunctional tear syndrome, or keratoconjunctivitis sicca. So the Tear Film and Ocular Surface Society Dry Eye Workshop defines dry eye as and I'll read this specifically, but it's dry eye is a multifactorial disease of the ocular surface characterized by a loss of homeostasis of the tear film and accompanied by ocular symptoms, in which tear film instability and hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities play an etiological role. And we can think about it mainly as the tear film has lost its ability to maintain its homeostasis, which can manifest as a lot of different symptoms that we're going to see. So why should we care about it? Well, dry eye disease is one of the most common presenting symptoms during an eye exam, and it can affect our visual acuity and our visual quality. A lot of the eye surgeries that we may need can cause or exacerbate the signs and symptoms of dry eye disease, and topical medications that we may take can also be exacerbating those dry eye signs and symptoms. If you're a contact lens wearer or considering wearing contact lenses, if you have dry eye disease, this is something that should be considered. And I do see a lot of patients that come in, they either are wearing their contact lenses and they have terrible symptoms and they just don't understand why they are having those symptoms. Or on the flip side, I'll have a patient that comes in and one of their main complaints is that they have these dry, irritated eyes, and their next question is, can I have contact lenses? So we'll talk a little bit about that as well. I don't know what happened there. Okay. So just a little bit more about the epidemiology of it. So in everybody, the general population, it's said that 70% of people that use these electronic devices or just visually stimulating uh, modalities, about 70% of them are going to be symptomatic for dry eye syndrome or dry eye disease. About 38 million people in the US have symptomatic dry eye, and that's symptomatic dry eye. So, we can have signs of dry eyes without symptoms, which means that number is actually, you know, probably a lot higher. And there's so many different statistics as far as the number of people that actually have it. But I think the general consensus is that around that number in the US have symptomatic dry eye, which is about 1 in 7 people in the United States. It's more common in women than men, and that has a lot to do with the hormones. There's an increased prevalence with age, and most of the patients that come in with dry eye syndrome have the evaporative component, or at least have that as an adjunct to their disease, and we'll talk about the different types of dry eye as well. And then as far as surgeries to the eye, so LASIK in patients after 6 months postoperatively, it said that 20 to 48% of them are going to have symptoms from dry eye disease. And, I think cataract surgery is actually a little bit more of an alarming number because greater than 80% of those patients are going to be symptomatic for dry eye. So a little bit of that probably has to do with the fact that most people who are getting cataract surgery are going to be, a little bit more mature or older in the amount of time they've spent here on Earth. Uh, but nonetheless, something we need to consider. Okay, so what are some of these modifiable risk factors? So there's broken them into four different sections, but environmentally. So we talked about kind of a dry air. So when I was in the Middle East, that was something I experienced for the first time, was how dry the environment was there and how I myself even started manifesting symptoms. But it was one of the most common things that brought people into my clinic there. Uh, and I won't go over every single one of them since the list is there. I'll kind of hit on the high points, but medication related. So have a lot of patients that will come in for an itchy, irritated, sandy, gritty eye, and a lot of them say that they've been taking over-the-counter antihistamines, whether that's topically or orally. And what they may not realize is that while they might have allergies or seasonal allergies, if they also have dry eye disease, they may be worsening the effects of their dry eye, therefore causing more symptoms. And so maybe their symptoms are more so related to the dryness and not so much the allergies. So there are a lot of ways that we can identify whether a patient has eye allergies, and then we can educate our patients on whether or not they need to be using a topical, uh, eye drop, whether over the counter or prescription. But the list goes on and on. And like I said, I didn't put an extensive list on here because it would be a number of slides. But a lot of our medications do end up having dry eyes as a side effect. So we talked about the refractive surgery and cataract surgery, but it's a modifiable risk factor in the sense that if patients are considering getting refractive surgery or cataract surgery, they may want to hold off on that if necessary, or if they're able to for cataract surgery. But for refractive surgery, being more of a cosmetic procedure, uh, it may be something to deter them from not wanting it. And then our contact lens wearers as well is something else to think about. Behaviorally, number of patients that come in with these symptoms of dry eyes, or they know they have dry eye disease, yet they continue to smoke. And it's a difficult conversation to have with our patients because I don't think anyone smokes thinking that it's good for us, but it can be maybe frustrating for them because they don't understand why their dryness isn't getting better, and a lot of it has to do with the chemicals that are coming off of the fumes of the smoke and just what the components of a cigarette cause systemically and have kind of that secondary effect. But alcohol, poor sleep, and an unhealthy diet also have an effect. So here's a long list. And again, this I could go on and on with kind of systemic and just demographic, ocular risk factors that are involved here. But Dr. Parker was talking about having, eye makeup on her eyelid margins, and we're gonna look at a lot of pictures, and hopefully by the end of this get a good understanding of why being aware of the anatomy of the the tear producing sections of our eyes, why knowing where those are at may help us kind of modify some of those behaviors. But eyelid tattooing, I see that kind of frequently with the eyeliner and the damage that that does to our meibomian glands. Um, so won't spend any more time on that. Let's go to kind of what dry eye syndrome is in relation to the anatomy of things. So we'll start with the picture on the top left-hand side there. And so the tear film sits on top of our cornea, which the cornea is kind of the outermost clear tissue, the most front part of the eye. If I were to, touch my eye straight on, which I would not encourage anyone to do, but if I were to do that, I would be touching my cornea. And on top of that is our tear film, and it's composed of three different layers. So the one that's most intimately associated with the cornea is the mucin layer, which is produced by these little glands. And I'm sorry, I don't actually have that on here, but there are these glands or these cells called the goblet cells, which actually exist on the conjunctiva. And the conjunctiva is a clear tissue that is on top of the white part of the eye, the sclera. And it really helps to regulate surface tension and keeping the tears onto the cornea itself. The aqueous layer is produced by the main lacrimal gland, which kind of sits behind the eye in the globe. And there's some accessory lacrimal glands that live within the eyelid itself. And then lastly is our lipid layer. So that lipid layer helps prevent evaporation of that aqueous layer. And so what I like to tell my patients is that, what happens to water if we leave it outside? If we let it be exposed to the environment, it's going to evaporate. So we need something like a lid to keep that water onto the ocular surface. And then that picture down at the very bottom left, you can see those meibomian glands and how they're deeply oriented in the eyelid. So that is important because some of our treatment options are that we'll talk about and how we can manage or improve that lipid layer. If we understand that there's a thin layer of skin and some muscle tissue that before we even get down, or we have to kind of get beyond those areas of the eye in order to even get down into the meibomian gland itself. And then, just the overall process that occurs. And the next picture, we'll be able to see the meibomian glands. But in order for the lipid layer to secrete out of the meibomian glands, it requires for the eyelids to blink and make that contact with one another. And when they do that, that secretes the meibum out of those glands. And then in that blinking motion as well, that also pushes the tears. If you look at the picture over on the right-hand side, it pushes the tears out of the puncta. So you have a superior punctum and a inferior punctum. And so then your tears will drain through that process there on the right. So the meibomian glands. So on the left-hand side, you can see that there's a bunch of them on the upper and lower eyelids. You have about 20 to 30 on the top and about 40 to 50 on the bottom. And what that meibum does is it's going to stabilize that tear film, keep it on, keep the tears onto the eye, and then, it doesn't do a lot of the reducing of the surface tension. Again, that is the mucin layer, but it does some, and it just makes sure that all those other tears don't evaporate off of the eye. So I want to bring your attention over to the right picture now. So this is when we are assessing the meibomian glands under the slit lamp. This is the view that we get. And so right in this section here, you're going to see these little tiny holes, and that is the orifice of the meibomian gland. And when the oil, or when we blink, that oil should be a clear fluid coming out of those glands. So for anyone that wears eye makeup, be considerate of that. I think in the makeup world, they call that the waterline. It's the discussion I had with Dr. Parker. But I see patients that will come in and they will have concealer that just completely coats that entire eyelid margin, or they'll have their eyeliner that they've completely just, put on that waterline area. And if you think about it, if that's where you're putting your eye makeup and that's where oil should be secreting out of, well, with the blinking motion, what's also being secreted with your oil is your eye makeup. So you're going to be looking through that. And then another just consideration for these meibomian glands is when you get an eyelid tattoo, think about that tiny needle going in and poking those glands. Okay, so this is a pretty busy slide, but it goes over the two different kind of types of dry eye dry eye disease. We have the aqueous deficient type or the evaporative dry eye type. And we used to think that they were, separate, but now we understand that most patients are going to have a combination of both. And so understanding what dry eye is and what can cause it, there are questions that we should be asked during our eye exam. So we should have a good understanding of a patient's medication history, asking questions like, do you have dry mouth? Because that would be important with something like Sjogren's syndrome. Do you sleep with a fan on or near an air vent? Because that can really increase and exacerbate the evaporative components. With sleep apnea, these patients may be sleeping with a CPAP machine, and that's going to further dry the eyes out. The eye surgeries question, contact lens wear, and this is one of the big ones. Does your vision fluctuate with blinking? It's something that I see very frequently, and it's something that I tend to ask a lot during my eye exams because I want to know that prior to doing the patient's refraction before we get them some glasses, because that may have an impact on their subjective responses. And we will talk about that. I've got some good slides to kind of go over why that's the case. And then the eye exam we'll go over as well. So what do patients come into the clinic complaining of? So we can hear a number of different things, anything from burning eyes, my eyes are sore, so it feels like I have something in it, eye pain, doing consultative care for the emergency department and ICU and worked for some urgent care clinics as well. Can't tell you how many patients will come in and the end result or what I'm getting a consult call for is for dry eye disease. But these patients feel like, they're incapacitated with the amount of pain that they're getting from their dry eye disease. We talked about the fluctuating vision, and again, I'm going to go over that. Patients can be light sensitive, and they may also just complain of difficulty finishing their work or having a hard time, making it throughout the entire day without their eyes becoming uncomfortable. The other one is watery eyes. So that one confuses patients a lot because you'll tell them they have dry eyes and they'll look at you confused and they'll say, well, if anything, I have wet eyes because all they do is water. And, reason for that is because there's actually a lot of theories that go into this, but primarily what occurs is it's a reflex form of tearing. The eye, is overly sensitive and it has a way to, produce tears as a reflex to get rid of um, debris or any foreign agents. And it's an attempt to make the eye feel better, but doesn't do the best job at doing that. All right, so which is better, one or two? Everybody's favorite question when they go in for an eye exam. And this is a big point that I like to make. And the reason I want to make it and the reason I want to spend some time on it is because I mentioned also that I'm a low vision specialist. So I get a lot of referrals from a variety of different subspecialties within the eye community. And with these referrals, these patients that I'm getting referrals from have a number of different eye conditions, from glaucoma to macular degeneration to inherited retinal diseases, and they're being managed really well for those conditions specifically. But a great majority of these patients, I would say, also come in with severe dry eye disease. And in some cases, when they're referred to me, they're taking a handful of topical medications, which, as we saw in the risk factor slide, taking topical medications, some of those preservatives can worsen the effects of dry eye disease. And all of this to say that when we're referring patients for an eye exam because their vision isn't, 20/20, and we feel that maybe a refraction may benefit them, then, to my fellow eye doctors, what I would suggest, especially in the subspecialty world, is that we consider managing the dry eye disease, or at least getting them to manage that prior to having them be evaluated for glasses or any optical device. And just some other information there, but I really want to get into the next slide. And so why does this even happen? So I spend quite a bit of time in my low vision clinic especially, but I do it even in my general clinics, because I find that if we have an informed patient, then we have a more compliant patient, and we also have a happier patient, because there's the expectation management is set for their vision, and then just overall how their eye's going to feel, or how they should expect for it to feel. So this is kind of the conversation that I have with my patients. We go over just the general visual pathway. So this is just a very simplified description of what happens. So light has to enter into our visual system. And what it does is light enters in through this hole right here called the pupil, and it traverses all these different media, and these different refractive components help take this diffuse light, and they bring it to a perfect focusing point onto our macula, which is our macula is a part of our retina, and then the retina takes that perfect focused point there and creates a kind of a visual signal, we'll call it. And then the retina, or the macula, both of which take that visual signal or visual information, they send it to the optic nerve. And the optic nerve is like a cable. It inserts into the back of the eye, and it travels from there all the way back to the occipital lobe of the brain, which is the back part of the brain. And then the brain takes that visual signal and creates an image. So there's a lot more scientific, terminology, and definitely more of a process that's involved than just that. But why that's important to understand is because whenever we are prescribing glasses, for instance, or contact lenses, what those treatment options are doing is they are helping to bring the focusing point to the macula. So, in a simplified way, if the cornea, the tear film, the intraocular lens that's right here, if when light enters into this person's eye and it comes to a focusing point in front of the macula, then that's what's called nearsightedness. And so what glasses or contact lenses do is they're going to help bring that focusing point back to the macula. And then on the flip side, if the light comes into a focusing point behind the macula, then that's farsightedness, and glasses or contact lenses bring it the other way. So a couple things are required, though, in order to get light back there. We have to have clear media for it to travel through. And so that's why we're going to focus on this part of that process. So light traveling into the eye, focusing onto our retina or the macula. So this is just a little depiction that I've drawn here. And we'll go to this slide. So there's a few things that can impact the way we see as far as that other process, that those first two steps are involved. And what it has to do with is it has to do with either an instability in some of these layers or due to interferences with the clarity of the media. So first up, over here to the left, this kind of greenish color here, this is called sodium fluorescein. It's something that we use in order to, well, we just skipped through a bunch of different slides. We're gonna go back. Oh, well, we just went through. So, um, give me 1 second here. I'm using my iMac and the mouse. I have a bone to pick with the creators of it because it's not the best. Okay, we're getting back there. Here we are. All right, so the the sodium fluorescein, what it does is it the tears pick it up, and when we use a blue light, it will glow this green color. And what we should see is right when we put it in, right after a blink, we should see an evenly distributed pattern of that green dye within the tear film. And as you can see in this person's eye here, they have some negative areas, some dark areas throughout the cornea. So that's irregularity. So when light travels through that, certain light is going to pass through maybe easier, while other light is disrupted by some of those irregularities. So if we look at the schematic here, with light's going to be kind of, if some of it is making it through, some of it might not be, or some of it is reflecting rather than traveling through, we are not going to get this perfect image of this avocado back here because some of it is going to be lost within this abnormal tear film. We travel over here to the right-hand side, you can think about it as a smudge mark on your glasses, right? So if we put glasses in front of the tear film, which is in front of the cornea and the intraocular lens, and we put a smudge mark on it, the light is going to be interfered by the smudge mark, and that is what we are going to see. It's going to be kind of a smudged, cloudy appearance. And then I think that the point is coming through that you can have dirty contact lenses, and that's just another added refractive component within the system. And then lastly, I just put cataracts in here because it's another conversation that I have with many of my patients and what a cataract is. But that lens sits in this area, and if we put a cataract, which you can see down in this picture, that doesn't look so clear. You're not going to see through that. So that's going to interfere with the ability of light to transfer through the lens. Okay, so where should patients seek care? And I think I've seen this question quite a bit, or maybe concern, working at a more medical practice like Emory, because patients come in and they just don't know the difference between an optometrist or an ophthalmologist, or if they need to see a cornea specialist. And I think that one of the common misunderstandings is that optometrists are for glasses only. And while we do plenty of refractions, and that is one of our primary things that we do, we are trained and we are licensed to be able to diagnose and manage a number of different ocular conditions to include dry eye syndrome. But if, being one of the primary eye care providers, if the condition is, more complex, or there's other factors to consider that may be outside of our scope, we as an optometrist would refer over to our ophthalmology colleagues who specialize in eye surgery and advanced eye care. And so if for you, your primary eye care professional is an ophthalmologist to begin with, then that might be the person that you start with, is your general ophthalmologist. But if your primary eye doctor is your optometrist, you can start with them, and they should be able to assess if it's something that they could manage within their clinic or get you to an ophthalmologist. And then in our, even more advanced cases of dry eyes or patients that are very resistant to treatment options, you may see some of our ophthalmology providers referring over to a cornea specialist. So what to expect during your eye exam? So your provider should be taking a very thorough case history when it comes to your dry eyes. As we can see, there's a lot of things that we need to understand in order to know what exactly is causing your symptoms and to just ensure that the signs that we're even seeing make sense with what symptoms you may be having. The preliminary tests that you'll have during most eye exams, we'll do your visual acuity, we'll check the pressure, we'll check your peripheral vision, and make sure your eyes are moving appropriately, and also just do a pupillary assessment. And then there should be a slit lamp evaluation where this piece of equipment here is used in order to view the eye under greater magnification and with good illumination. Now, I use some AI images to help me in my presentation, and this is one thing that really irritates me is some patients, we need the forehead against this forehead rest right here. And patients just love to lean back. And when they lean back, we lose focus in our system. So for everyone that's listening, if you're planning on getting an eye exam, this is just a PSA. Try to keep your forehead against that forehead rest if you can. Helps us out. All right, and then you should be getting a good treatment plan from your provider. All right, so in some cases, the exam is going to differ from patient to patient. And there are many different diagnostic techniques and modalities that are available. And so I put a few of them here just so that we could take a look at them. But just to start, and I'm trying to be aware of the time, but some of the big ones that we're going to see in most settings is going to be the tear breakup time. So we put the sodium fluorescein in, we have the patient blink, and we assess it in the increments of time. And so anything really under 10 seconds, if it starts to break up. So you see the normal distribution on the left-hand side here, and then on the right-hand side, you'll see that there's some dark areas. Once it starts to do that, that's the end time. So anything under the 10 minutes or 10 seconds, sorry, that would be diagnostic of dry eye disease, and more specifically, the evaporative type. This meibography is something that's new within the last like 10 years. It's a great way to kind of show patients their meibomian glands and how we can make that better. I'm going to move to our next slide here because the big thing that we need to really consider is that dry eye is multifactorial and it's complex. And a lot of eye doctors have a love-hate relationship with it because patients are either not satisfied when we treat them initially, and so they're coming back constantly. But it's our job to then figure out what the next steps are for them. And I just think that we can do a little bit better within the eye community at managing dry eye disease. One of the things to do is to just reduce the amount of times we keep the eyes open. So remembering to blink. The 20-20-20 rule that you'll see there, what that is every 20 minutes, you're going to look 20 feet away for 20 seconds. And during that time, make sure you get some good blinks in. The other thing I'll bring attention to is considering the social determinants of health. Whenever we're managing these patients, we need to know, are these patients going to be able to be compliant with the medications that we're recommending? Do they have if they have insurance, but we're asking them to buy all of these over-the-counter options, are they able to afford the over-the-counter options? And, in the cases where they may have a large copay. So just working with the patient in order to get them the treatment that they need is very, very important. Here are just some other treatment options. Again, this wasn't really the intent or the purpose of it. Wasn't really treatment driven. It was more so understanding the disease. But for pretty much every patient that comes in with dry eye complaints, I'm starting them on this first line therapy, which is a warm compress mask So down on the left-hand side, you can see this is one that's called the Brooder mask. There are tons of different ones made by different companies, but they heat up different ways. You use it for 5 to 10 different minutes, or 5 to 10 minutes, and just some gentle massaging after that. You want to clean the eyelids because you got a lot of some microbes that live in that area. We take showers, we wash our body with soap and water, but we don't do that to our eyelids because we want to avoid getting soap in the eyes. So you want to use things that are safe for that area to clean up the eyelids. And again, I know we're running out of time, so um,
Yeah,
then the additional treatment options that are available. And I think I just have two more slides. Is that okay, Dr. Parker, or do you want me to wrap it
that's
up?
fine. No, you go on. You've got 8 minutes before we go off. But I've got some questions in Q&A that are, I think, appropriate to the discussion. I'm looking at all the stuff that you have here and I'm like, I don't think most of us use this, but go on.
Yeah. So, most patients are managed really well with the kind of the conventional therapy. But when we get into patients that are not managed at that state, we need to be considering these additional treatment options. And if it's not something that we feel comfortable managing in our clinic, then, we talked about those referrals to the specialists or even the subspecialists. But I tried to color code this system. So this gray options, these are some of the prescriptions that are available for treating dry eyes. Um, the 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 green down there, you'll see the scleral contact lenses. You can see the picture of a scleral contact lens. They're a larger lens. They actually sit on top of the cornea. They allow some tear exchange underneath them, but um, it used to only have one lens that was available, but most of them are or can be used for the treatment of dry eye disease. So that's one of the exceptions to contact lenses when we're talking about exacerbating the signs and symptoms of dry eye. This is one that helps them. And then, just there's a lot of different ways that we can provide heat to the area and clean them in office rather than cleaning them with those over-the-counter options as well. All right, so one of the other things I mentioned is just the importance of a multidisciplinary approach to dry eye management. So, in order to really consider patients being um, compliant with their medication, but then also understanding that the various medications that they're going to be prescribed, if we can have a team of us that understand dry eye disease and be able to know when referral is appropriate and you know giving our patients those expectations on, hey, this condition is also going to be associated with dry eye disease. You may need to meet with your eye doctor a little bit more frequently, and this medication I'm prescribing you also may cause dry eye disease. So having good interprofessional communication is really important. Yeah, in summary, we went over dry eye disease. I hope everybody has a better understanding of what it is and how it affects things like our vision and know the importance of educating our patients because it helps with how compliant they are. And yeah, thank you for your time. So this is
Thank you. So let me ask you a question, Dr. Gosh, just because we only have a couple more minutes. There are a couple of questions here about contact lenses. Those of us who have worn them before were told to take them out every night and moisturize. And then there are some people with the questions. It's like, should you keep your contact lenses in overnight? And then the other thing is, if I sleep with a ceiling fan and if I'm wearing my contact lenses, is that okay? Is that going to protect my eyes? And if you look in the Q&A section, not the chat, the Q&A, there are a couple of other ones, but let's address the idea of contact lenses in your eye overnight. And is this going to keep your eyes moist? That's twice. It's in Q&A and it's over there in chat.
yeah, so contact lenses are actually something that are can be amazing. They can improve our quality of life for a number of reasons and they can provide really good vision. But contact lenses are also something that can be very, very risky. We're thinking we're putting a medical device onto the eye itself. And when we do that, we are always going to have the risk of having our contact lens collect different microbes and if we already have a dry eye, that is causing compromise to our cornea, which is a clear tissue. So if we're having corneal compromise, and then you put a contact lens on there that's not very clean because we're not the cleanest people in the world, and then overnight you're sleeping in it, that's increased contact time. You're increasing your risk for a corneal infection. And, especially deploying to places like the Middle East where microbes are a little different, I can't tell you the number of patients that either had to have a corneal transplant or they now have a huge corneal scar in their vision because of the fact that they slept in their contact lenses. Now, I know that I'm also not a contact lens specialist. Dr. Severinsky at Emory, he might disagree on this, but for me, I generally try to steer my patients away from sleeping in their contact lenses unless it's absolutely necessary for their job, or at least ensuring that they are doing a really good job at cleaning their contact lenses.
Okay, on that note, let me get this other one here. In the Q question and answer section, there is a question about eyelashes, false eyelashes or the implants. I mean, you told me to start putting my eye makeup on top of my skin and not my waterline, but what about these, not the glued lashes? I'm assuming they mean the individual lashes.
Yeah,
And eye tattoos. I think Emily talked about eye tattoos, and I'm like, I thought that was going to be a good idea, but apparently it is not. So,
yeah, I mean, if you think about it, you're always posing the risk whenever you penetrate that area, you are always going to assume the risk that you may cause, when you penetrate that gland by chance, you could cause long-term damage to it. If something is compromised in a way that the gland can't recover from, we may see things like atrophy of the gland a little bit sooner. And there's some research to suggest that eyelid tattooing, and some of these newer eyelash extensions that are more of like a needle kind of plug into the eyelid itself, that they are having an impact on the meibomian glands and the way that they're secreting.
so my take home for that is instead of just washing our face with little or nothing, make sure we go take time to spend money to buy the eyelash cleaner, and we should use that every night.
Yeah, that's absolutely right. So, if especially if you're, everybody, in my opinion, should be cleaning their eyelids. We take a shower, like I said, with soap and water, hopefully every day or at least once every other day. But we want to do the same thing about cleaning up that area of the eye, because again, it's such it holds our most valuable sense, which is our sight. Again, that's subjective. I feel like it's our most valuable sight, but uh, it yes. So in yes, to your point, Dr. Parker, it is something that I would suggest that, especially if you're wearing eye makeup, to get one of those eyelid cleansers that you can really take off that residual eye makeup.
What about baby shampoo?
Baby shampoo was kind of the gold standard or go-to option. It certainly does a good job, in my opinion. I like kind of having that solution on kind of a towelette that I can really kind of get on and kind of create that friction to get off some of that debris. They feel a little bit cleaner in my opinion. I know my patients tend to like it a little bit better than the baby shampoo.
Mhm. Okay, all right, and I'm gonna get this one from Mr. Bob Dobbin. He says, are Bates method eye exercises, figure eight, sunning, closing, then distant focus helpful in alleviating dry eye syndrome?
Can
I've never heard of
you
that.
repeat the first part of that?
Something called Bates method eye exercises helpful in alleviating dry eye syndrome. Are there exercises that you should do that keep your eyes moisturized? I guess is the baseline question.
So I'm not familiar with that method in particular, but we mentioned the 20-20-20 rule, because we're seeing a lot of dry eye and the incidence is on the rise with the increase in the amount of time we're spending on a lot of these electronic devices. We aren't blinking when we're doing that. And again, that oil layer is only being secreted when we make that blinking motion. Um, or it's primarily being secreted when we make that blinking motion. So if we're keeping the eyes open for too long, it's not being secreted. So that 20-20-20 rule, again, every 20 minutes, you look 20 feet away for 20 seconds. And during that time, you're getting some really good blinks in.
Okay, and the last one I'm gonna go over here, what are blue, there are a couple of questions about driving at night. What's the best way to improve your night vision? And this one's important. What about using over-the-counter antihistamine drops during allergy season for eye dryness and irritation? Is that something you should do?
I think it's okay to use as kind of an initial trial. You're certainly not going to harm your eyes, but understanding the difference in the symptoms. So an allergic conjunctivitis is going to be more so of an itchy sensation. It's going to feel like you have to kind of claw your eyes out, but you can have those same symptoms with dry eye disease. And I will say most patients end up having a combination of both. So my recommendation is like if you don't have the ability to get to an eye doctor, you can always try it, see if it improves your symptoms. But I think it's sometimes better to just go in and have it looked at. That way you're not doing something that's one, not working,
Yes.
and or you're making something else worse.
Okay, thank you so much, Dr. Gosh. We really learned a lot of very basic kinds of things that we all should know. And I thought I knew something, and I'm a primary care doctor, so